and that is combining abdominoplasty with liposuction. The truth is, numerous controversies abound regarding this. Basically, many articles warned against combining abdominoplasty with liposuction, that the skin might die. Matarazzo in 1995 wrote an article that everyone quotes that basically says you cannot do it. And then in 2000 he partially reversed his stance that you could combine liposuction with abdominoplasty given the following conditions. And there's the list of conditions. You can see they're long and many. The bottom line is liposuction can be, at least he felt, combined with abdominoplasty with significant alterations in both the technique and the amount of liposuction. Other surgeons came by, great surgeons, and recommend that you could combine liposuction with abdominoplasty, but you had to significantly alter your abdominoplasty technique. So we're familiar with the Lockwood high lateral tension abdominoplasty, where only minimal undermining in the central aspect of the abdomen, or the avalar abdominoplasty, which basically doesn't undermine, cuts out a little skin below and sometimes underneath the breast to lift up in that direction, and leaving scars and maybe not as a great improvement, also that you can do some liposuction with it. And then finally, the most definitive thing is the maintenance of certification of exam that I had to take to recertify my plastic surgery boards. And of course, this is always the definitive answer, and they say you can't do it. That's the answer for the test. Okay, so is that true or not? Well, let's look back. This is a transaxillary breast augmentation patient of mine. I noticed she had a great abdomen, so I took that picture. And we're all familiar with Hoyger's 3 zones of abdominoplasty, basically zone 1, 2, which is mainly incised, and zone 3, and 1 is sort of the danger zone. And it's based on the vascular supply to the abdomen. And if you look prior to abdominoplasty, you have all these vessels that supply the abdominal wall. You can see it's a large number of blood vessels supply the abdominal wall. And then after full abdominoplasty, only the segmental perforators remain, making liposuction in the central abdomen dangerous. If the superior superficial epigastric arteries are preserved, most of the vascular supply to the central abdomen should remain. This was my hypothesis, that you could do abdominoplasty, regular abdominoplasty, and safely combine it with aggressive liposuction if you spare a couple of those perforating vessels. So, as fate would have it, these vessels are fairly consistent and easy to find. If you make a line below the subcostal margin and then one down the center of the abdomen, you'll find that 4 centimeters from the center and 6 centimeters down from the subcostal margin lie the perforators, plus or minus 2 centimeters on a fairly consistent basis. Now there's the perforator right there. You can see there's the midline, 4 centimeters from the midline, 6 centimeters down from the subcostal margin. See some very robust perforators. And sparing these should therefore theoretically spare most of the blood supply to the abdomen. There they are in a consistent location. So I did a retrospective review of 300 consecutive cases from 2005 to about 2009, and then we followed those in 2009 up to a year. So we went to 2010. And these were 300 consecutive cases. We do about 50 or 60 a year. Complications were reviewed. 75% of the abdominoplasties were combined with other surgeries. So this is an interesting thing too. We combine them with other surgeries. The most common being flank liposuction, and then the second most common being breast procedures. And then 3 or more procedures were in 40% of our patients. So it's also the other thing we get out of the study. It's safe to combine procedures if you do it, properly. The surgical technique is just the standard technique. Elevate the standard abdominoplasty flap to the subcostal margin. The yellow, where I've marked it in yellow, are the only differences in the technique. Spare 1 or 2 of the perforating vessels. Plicate the rectus muscles as you would. Pull down and incise the skin aggressively. I temporarily staple the flap closed at that point. Infiltrate the abdomen 1-to-1 ratio, and then liposuction aggressively. We then remove the staples and then close the abdominal flap. No change in your technique other than sparing that vessel and adding liposuction to it. These are our complications. An average amount of our aspirate was about 660 cc's with a range of 2,200 to 75. So you have to remember 660 is fairly reasonably large amount considering we cut off the bottom half of the abdomen and threw it the garbage. So it's really the upper abdomen that we're getting 600 cc's out. But it's also anterior flanks too. So in fairness, it's not just upper abdomen, it's anterior flanks. We had a 17.3% complication rate, 52 patients. Most of these were minor. We only had 1.3 major complication rate. And this complication rate is consistent with other large studies for just abdominoplasty alone, and various studies range from 14 to 27% complication rates. This is no different than those studies. So abdominal scar or standing cone or umbilical revision was by far our most common complication, revising the scar and the umbilicus a little bit. Seroma being the second most common at 4.6%, again consistent with other studies, not more or less. Minor dehiscence, a tiny opening, occurred in 8 patients, nothing major. Minor infection requiring PO antibiotics longer than the 1 week that I usually give them, occurred only in a few patients. And then we had 2 pulmonary emboli. Both of the patients were older than 60 and large amount of suction and resection, and neither one of them were fatal. We had 1 fairly serious infection. We had to do IV antibiotics. Because I have my own surgery center, it's kind of like a mini hospital there. We actually just did that in our office. He came in every day and we gave him some antibiotics in the morning and at night intravenously, and the infection went away. And then we did have to give 1 blood transfusion on the lady where we did a mastopexy, a very large abdominoplasty reduction, large flank liposuction, and we gave that to her about 36 hours later just because she was very weak and pale and probably needed the blood from the large amount of resection. So these are the results, and this is only a single surgery. It's about 9 months post-op. You can see these are fairly impressive results with just 1 surgery. Only possible if you combine these 2 and combine them aggressively, not a little tiny bit of liposuction. You can see we've done a lot of liposuction. I threw this picture in. She's only post-op about a month on purpose, and the reason I threw that in is so you can see the redness of the scars. Very obvious that this is fresh post-op. She's still swollen. She's still getting better. So, if the argument is made, well, maybe they just lost weight, Dr. Smith. Maybe 9 months later they lost 20 pounds and they look really good. Here's one, right after surgery. She hasn't had time to lose any weight. You can see the changes are fairly strong there. Again, about 4 weeks post-op. Here again, another patient. Again, flank and abdominal liposuction, fairly aggressive, and get some very strong changes. And you can see nice changes there. The other thing is it's possible to safely combine this with fat transfer to other areas, and specifically the buttocks. And so if you look at this patient, you see the buttock is nicely rounded and improved. You look here, the abdomen is flat. I like this. This is important. The curve is deeper, and then the flanks also being narrower. And when you have all of these procedures, or all of these changes and procedures combined, you end up with a much sexier figure. Not just a little bit sexier, but quite a bit sexier, quite a bit curvier. So in conclusion, here is Matarasso's recommendations for combining liposuction with abdominoplasty. All of those things with little stars don't have to be done. Okay? If you spare 1 or 2 of the perforators during abdominoplasty, you could do standard abdominoplasty with full undermining and aggressive abdominal liposuction with no increase in complications or risk. And the ability to combine liposuction with abdominoplasty makes it possible to have impressive improvements in body contouring in a single surgery. Thank you.
Thank you. All of our speakers have been great about time. So we have a few minutes for questions. Yes, ma'am.
So you combine the abdominoplasty with the fat transfer to the butt in the same procedure?
Yeah.
How do they recover? I mean, do they just sleep on their side?
No. There's a really nice book on buttock reshaping by that guy in Miami. His name starts with an M. And he has a picture in his book, and that's actually for butt implants, but we use it for the fat transfer. You kind of put pillows behind the back and pillows under the legs, and you don't let them actually lie right out directly on the buttocks. We actually give them that picture and say, okay, do this. But there are people who don't think it matters. They think that you can just lie on the buttocks after fat transfer. I don't believe that. I don't think that's true at all. I think you need to stay out fit as much as possible. But in my own town, some guys said, oh yeah, you don't have to do that. But yeah, you do have to do that. You have to stay out fit. That's a good question. Thank you.
I have one for you. Which liposuction technique do you prefer to? Traditional, say?
Yeah, because this was made for the Califonia Society, I just threw it together today. It's a real quick amount of time there, and I would have gone into more detail, but the truth is I don't feel it's safe to do the ultrasonic. I feel like that could hurt the vessels more. I have a laser. I don't feel like it's safe to do the laser either. I feel like that could hurt the vessels more. So I like to just use the super wet technique, just regular old liposuction with the super wet technique. I'm really afraid those other modalities are going to hurt the blood vessels, and you know, you might get some necrosis of the abdomen.
Do you do the liposuction closed first, or do you do it after?
No, I do it after. That's it. Yeah. So we lift it up, tighten the muscles, pull it down, temporarily staple it. At that point, infiltrate it, suction, take the staples out, and then close. You staple it because you don't want to hold the flat once it's moving around. So you staple it kind of close to the environment.
Any other questions?
Any other questions?
Okay, all right. Thank you very much.
Thank you.
Okay, our next speaker is